I shall be speaking on computerized physician order entry, time for a medical prescription. So let me be candid with you that I am not going to say anything very unusual or very new, what has not been so far covered by my illustrious predecessors. But however, I shall be focusing on this niche area of which detail we have not gone into as yet. So this is one end of the spectrum, a kind of application which has got benefits as well as high costs, but it has got its pitfalls also, and I shall be focusing on this, and some other facts I shall be projecting in a different perspective from different angles. So let me start by saying that what we have been covering for last 2 days, deliberating in last few sessions, is not a figment of imagination of few IT savvy geeks. It's a part of Millennium Development Goals of UNO, particularly Target 18, which states, in cooperation with private sector, make available the benefits of new technologies, especially the information and communications. That's what this government is trying to endeavor. When it comes to technology, all sectors are lagging behind. All institutes are falling behind the pace of technology. It's advancing at such rapid strides that BFSI sector, that is banking, financial, insurance and services sector, is even lagging behind. For medical sector, we came up with several reasons in the last few sessions, like doctors are not techno-savvy, or there are a lot of barriers, the cost investments are very high. But one point I would like to add here is that implementing in healthcare is not so easy, because the healthcare processes are very complex and they are individualized for each patient. So you can do it for back-end repetitive factory-like course like selling tickets in Indian railways or in banking sectors. But in healthcare, one must bear in mind that the processes are very complex. So you are familiar with all these applications. Some of them we have deliberated upon and some we need to discuss. And I shall be focusing on computerized physician order entry or computerized provider order entry, because in some places even the advanced nursing practitioners in US are also prescribing medicine. Look at this matrix. It says along the y-axis what is the impact of the technology. Along the x-axis what is the cost of each application. So as far as high cost and low cost and low benefits are concerned, high benefits are concerned, do those activities first. So there is no doubt about that in the mind of our clientele. And as far as high cost and low impact applications or solutions are concerned, don't bother about them. So CPOE comes in high cost and high impact. So this is a niche area of ICT applications in healthcare that comes in this arena. And this should be thought of after you have implemented the basic modules of HIS and decision support system and EMR, and then you can think of CPOE. Now this is all well with technology. My only apprehension is that there's only one flip side. We shouldn't go this way rather than happening with some of the technological applications. Before I proceed further, let me give you a brief premise on what are adverse events which we are concerned about, what is the part of patient safety program and what is patient safety management. So there are a lot of adverse events which are happening, for which we have been discussing that we need to develop a dashboard, we need to monitor these events. So what are these events? So firstly, an adverse event is an injury caused by medical management rather than by the underlying disease. It includes trips and falls, cases of electrocution happening in our hospitals, bed sores, hospital-acquired infections, and wrong side surgeries as well. Whereas adverse drug events or the medication errors are a particular subset of these events, and they too occur frequently in hospitals. But we must bear one thing in mind, that not all errors lead to patient harm, and not all errors are preventable. So by implementing ICT solutions, we can prevent some of the medication errors, but some shall still be inevitable. So what are these medical errors we are concerned with? What is the extent and magnitude of the problem? So let's see various reports. One WHO report says that 1 in every 10 patients who are admitted in the hospital is harmed. It's much safer to fly in an aircraft. You need to go around the earth 436 times before there is a probability of individual's death. But OTs in Indian hospitals are much unsafer than that. Other reports, like the latest report from Health Media Group, which has been published in August 2009, says that 200,000 deaths per year due to medication errors and hospital-acquired infection in US alone. And the better known report has been by the Institute of Medicine, published in 1999, which says that as many as 99,000 deaths per year in US. In India, unfortunately, we don't have a system of reporting. No doctor would like to say that you have a foreign body inside, or no hospital will say that there was a trip and fall in our hospital. So, first thing is to generate the data. But it is estimated that this is 3 to 5 times higher in Indian hospitals. Look at this another clipping in Times of India. How many deaths per year are caused by prescription drugs? The Journal of American Medical Association reports that between 60,000 and 106,000 deaths per year are caused by prescription drugs. Most of the deaths were due to result of adverse reaction. So these are the problems we intend to address with systems and applications like CPOE. Now, in a study done by Bates, out of the 4,000 adult admissions, there were 247 adverse drug events, which means an event rate of 6.5 per 100 admissions. So it's not that the data is not available. The hospitals which are patient safety conscious, they have been able to have sufficient data and information on these aspects. While medication errors occur frequently, most do not result in actual harm, but those that do are costly. Even at the rate of 2% of admissions, this works out to be $2.8 million annually for a 700-bedded hospital and $2 billion for the American nation as a whole, which is quite a huge amount. 28% of the 247 adverse drug events were from ordering and administration, admissions, and were preventable. So this is the benefit. This is the benefit we will get by implementing a foolproof CPOE system. What are these medication errors due to? These are due to omissions, duplications, dosing errors, drug interactions, or medication reconciliation. Double-check medication regarding instructions, label, and wrongly reading the patient identity. There are communication gaps between the doctors and nurses and the pharmacists, and one patient is handed over from one echelon of care to the next echelon of care. Or there is a mistake or error in labeling of the bottles or containers, and there are a whole lot of drugs which are called in medical parlance LASA, look alike, sound alike. Say a doctor prescribes Clopidogrel and the pharmacist dispenses Clopidogrel. Similarly, all these examples with the look-alike and sound-alike medications are there which are presented before you. Say, I prescribe furantoin for diarrhea to my patient, then the pharmacist may prescribe something else. I prescribe mementonin for a neurological case, pharmacist gives amlodipine. So there's which is antihypertensive. So these kind of errors are quite likely to occur. And you can see that doctors are notorious for their own handwriting. Some of them can't read their own handwriting. So, what are the various factors which influence human error in medication error? One is the physician schedule. There are no laid down schedules for doctors. Residents may be working 24 hours continuously. There is no rest or cycles like shift. There is hardly any. And level and currency of expertise of the treating physician. Sometimes the doctor is out of touch, or when he comes across a rare entity, he is at loss, or there may be new drug about dosage he may not be very conversant with, then there may not be system in place for conducting double checks in hospital, in which one provider reviews and signs off on another's task. This has been recommended by eHealth. And this schoolboy tells his principal that I do have a note from my doctor, but nobody can read it. Similarly, horrible writing can make horrible mistakes. Now, AIIMS had organized a conference on patient safety last year, and we had Professor HOD from AIIMS yesterday. So they have a plan of keeping tab on medical errors as a part of patient safety program. So what CPOE can do about it? This is a process of electronic entry of physician instructions for the treatment of patients, particularly indoor patients under his care. These orders are communicated over a computer network. That means there has to be interdepartmental connectivity to the medical staff or to the departments responsible for fulfilling the order. So besides medication, prescription drugs, it also includes laboratory orders, radiology orders, pharmacy orders, as well as blood bank orders. So thus it's a computerized system that aims to reduce prescription and dosage errors, drug allergies and interaction alerts. Keeps physician updated on treatment guidelines as well. Prevents superfluous inventory, drugs that are not part of the standard formulary or may aid prescription of only generic drugs. Thus it's also a great aid in cost containment. It prevents medication errors due to human factors like poor handwriting, fatigue, mental workload or distraction by the physician. CPOE must support sophisticated decisions such as drug choice, dosage and patient monitoring strategy. CPOE could be integrated with pharmacy, lab workflows and inventory management, and it invariably is connected. Thus it can be viewed as a crucial system to prevent errors. All CPOs are interfaced with clinical decision support system. This is another application that provides alerts and triggers as a part of clinical guidance. A follow-up of Institute of Medicine report in 2001 advised use of electronic medication ordering with computer and internet-based information system to support clinical decisions. Now, what is a clinical decision support system or a diagnostic decision support system? It's a software that presents comprehensive list of possible conditions. See, the problem is that doctors and knowledge workers, they try to carry everything in their memory. That is not possible. Their knowledge workers, they are always encumbered with this load that is shown in this photograph. Unlike lawyers who have always their books to fall back to, or financial analysts who don't need to remember PE value of each and every company, the doctors have to carry a lot of information in their head and to apply it at the point of care on the bedside. But if you have clinical diagnostic support system that can aid you in prevention of failure to consider reasonable alternative diagnosis. This means it will prevent premature closure or cognitive failure, which means the failure of the judgment to diagnose the case properly. Say, case of fever with rash comes or fever with chills and virus comes, he doesn't jump to a conclusion that this is a case of malaria or a chicken pox. He can consider the conditions which are rare and less common entities like fluid, gangrene, etc., streptococcal infection. They can also be given to him as an option if he has an aid of a decision support system. So it directs physician to helpful medical reference, interface with CPOE and HIS. So all CPOE applications come with additional clinical applications and databases. These are rules engines, clinical data repositories, third-party drug databases, the organization's core information system as a data foundation. So what are the requirements for successful implementation and what are the requirements for CPOE of interest to defining its successful adoption? These are: system response time should be in sub-seconds. It should respond to the doctor's order e-prescription immediately. The workstation location should be convenient. It's not that he from the bedside, he has to go to the office time and again to prescribe. Either he should be having a PDA application or a mobile computer on a platform or a laptop or a tablet PC. It should be flexible. It should be 24/7. Data integration requirements, challenges, it should be addressed to, and it should be within the workflow transitions of the system. So what are the essential data integration requirements for CPOE? These are medical formularies of pharmacy and CPOE should be the same. So one can have a customized formulary or as Gangaraam Hospital has gone in for, or they can go in for MIMS or SIMS. In CPOE pharmacy interface environment, the CPOE medication order data feed must map perfectly with pharmacy data feeds. Otherwise, there could be mismatch and incongruity. Data must be imported through real-time interfaces, and data definition must be standardized to permit use with the rule engine or DSS logic. So that's what we have been discussing for last few sessions, that it should be I3D coded, it should be standardized, and data transfer from one department to another, it should be real-time. So what such a safety and system should entail is that every system is perfectly designed to achieve exactly the results it gets. And safety is a system's property. So your safety is as good as the system you design. So what are the benefits once you understood that what is CPOE and what are its requirements and what are the benefits of CPOE? So these are orders are legible, they are structured, prescriptions are complete and appropriate. There is a feedback to the prescriber, order entry is provided. CPO reduces the medication errors rate by 80% and by 55% for errors with serious potential for patient harm. So this is possible to develop metrics only when you are monitoring your data. You have a system in place where you have a reporting and feedback system of all adverse drug events. So other benefits are that it increases the provider efficiency. Your turnaround time to the pharmacy increases. He is able to keep the medicine ready before the patient comes to collect. It reduces practice variation. So there is an individual variation between the doctors is reduced. There is reduction in number of medication errors and adverse drug events, broad access to clinical literature of point of care, and integration of clinical evidence to current care processes. Other demonstrative benefits which have been brought forth by the hospitals are that Brigham Women's Hospital, there was 88% reduction in serious medication errors. So one of our colleagues in US hospital also mentioned that there has been substantial reduction in the medication errors. So in other hospitals, the reduction in average length of stay by 2 days, and pharmacy turnaround time is improved by 2 hours, while pharmacy charges patient dropped significantly. One hospital was able to report on how compliance with quality metrics improved as a result of CPOE. So that post CPOE, each patient was prescribed aspirin, MI case. Earlier it was being done in only 60% cases. We also heard that how the pharmacy profits have increased by 15% in Sir Gangaraam Hospital. So these are some of the demonstrative bases. So the requirements for successful CPOE implementation are that the organization must make a significant commitment. They should come from the top management of the hospital. Physician involvement in CPOE should be ensured right from the designing stage. If the user is not involved in the process, then the chances are that he may not use it as well. One disadvantage of CPOE is that current software and commercial products may not solve and can even complicate data entry, retrieval and exchange, as well as communication among the providers. So what are the steps involved when you plan a CPOE in your hospital? That physician incentive should be there, not in financial terms, but he should see visible dividends coming in terms of patient safety, avoidance of medication errors, and delivery of quality health care. The process redesign should be there, and there should be metrics which should be able to compare pre and post CPO implementation difference in delivery of healthcare quality. And then some amount of physician training is required on the desk and maybe by the persons who are familiar with it. So in other words, successful implementation of CPO needs a harmonious relationship between technology, people, and processes, which we have been emphasizing throughout the last session. So CPO can deliver standardized evidence-based practices, can be implemented while preparing for CPOE. And physicians and other clinicians who will use the system must all agree the benefits of such a system more than offset the efforts required to use it. This is the biggest stimulant for the use of CPOE. So to conclude, CPOE is a technology and asset and intercepts errors at the ordering stage in conjunction with point-of-care systems such as those that focus on the medication administration phase. A clear high medication safety environment is generated. So what is the current status in our scenario? So is there a time for radical prescription? My answer is emphatic yes. Most Indian hospitals have already gone in for CPOE. There will be substantial gains in terms of improved patient safety, turnaround times, and enhancement of operational efficiency, practice of evidence-based medicine, cost containment, and efficient inventory management. Now I'll just project you 2-3 slides which are generally about ICT. There are a lot of challenges which we all face in implementation of ICT applications, which we all too familiar with these by now. But I'd like to spend a few seconds on this slide, that if we use force field analysis of the various resisting forces or the barriers and the driving forces or the facilitators, and plot each of these factors on a graph of 10, on a scale of 10, then we'll see that the biggest impediment is the initial cost, which are shown up to -10, then clinician being uncomfortable with ICT, training of manpower, then inoperable or incompatible technological configuration. But if you look at the driving forces of the facilitators, the dividends are great in terms of competitive advantage, improved quality of patient care, patient safety, reduced costs in terms of more efficient inventory management, filmless and paperless environment, and then important improved operational efficiency by reduced turnaround time, workflow, average length of stay. If average length of stay is reduced, that means that more number of patients can be treated on same number of beds. So the biggest problem our healthcare infrastructure is facing is the shortage of beds right now. So if the average length of stay is reduced, then more number of patients can be treated with the same number of beds. So one more powerful chips, the price comes down, and as the volumes increase, today we are talking about even up to $10 laptop for each school child. Just look at this slide, how a 1 GB RAM was in size in 70s and how small it is in now. So this is what miniaturization can do to ICT technology. So my future vision is that each of the doctor will have a gadget like this, which he can use at his convenience at point of care, and he may be moving around tomorrow in a vehicle like this. And only flip side is people who use excessive IT, they shouldn't go with So one speaker admittedly lost his yesterday. So reducing errors in medicine, I don't want to make the wrong mistake. It may be the part of human nature to err, but it is also part of human nature to create solutions and better alternatives and meet the challenges ahead. Go as far as you can see and then see what lies beyond. The difficulty lies not so much in developing new ideas as in escaping from the old ones. If you are not riding the wave of change, then you will find yourself beneath it. So this is the parting message, and this is what we have been discussing in the previous session. Thank you very much for your time.